So let's talk a little bit more about targeted agents. So we talk about BRAF, we talk about EGFR status. Honestly, EGFR status and KRAS status we've been talking about for a long time when it comes to colorectal patients. But I feel like there's been a lot of exciting information and newer treatments that have been improved in the last couple of years looking specifically at targeted agents. So let's talk a little bit about that.
Yeah, so I think EGFR antibodies, as we discussed, about a decade and a half old at this point. We're still continuing to refine the exact patient population that will benefit the most from it. And so these are RAS wild-type patients, and for the longest time, the other half of colorectal cancer patients who have RAS mutations really didn't have targeted therapies, and for the RAS mutations were thought to be undruggable, and finally, over the last couple of years, as we've seen, we're breaking through that barrier, and we have some very effective therapies against KRAS G12C. Granted, it's a small proportion, maybe 2 to 3% of all colorectal cancer patients, but I truly believe that that's just the beginning. And with the kind of more extended KRAS inhibitors that we're seeing and pan-RAS inhibitors we're seeing, I think very, very exciting data to come, and hopefully standing ovations at ASCO.
Right. And just to add to that, one thing I emphasize always whenever I get an opportunity to do the NGS on these patients, the metastatic colorectal cancer patients, upfront. That gives you so much of leverage. Now, sometimes tissue is not available. We should do at least the liquid biopsy so that we'll get at least quite a few important information about the biology. So I want to emphasize this aspect.
I absolutely agree. And I want to touch on something you just said, and I want to ask you to dive into it a little bit deeper. So we talk about liquid biopsies and we talk about next generation sequencing. So I get next generation sequencing on every single metastatic patient without fail. Everyone, my fellows know, you get a metastatic patient, they get next generation sequencing. Liquid biopsy, there's more debate on who should get it and why should you get it. So what are your thoughts on that?
So liquid biopsy is logistically simple, easy to get. So I understand that liquid biopsy is not a foolproof way of genomic profiling, but often it gives you very valuable information, and the data are being presented that liquid biopsy is probably complementary to the actual solid tumor NGS. So my preference is to do both upfront, but if I don't have the tissue for whatever reason, sometimes the block is not available, at least I should do the liquid biopsy because, so let's say HER2 amplification, right? So Dr. Stickler last year has presented data showing that liquid biopsy can catch up to 80% of HER2 amplification. It's not 100, but it's 80, that's very close. And that would help quite a bit of patients. Same with MSI high. Sometimes the tissue is not available, but you can do a liquid biopsy and you can still detect MSI high, MSI high status. And that, that has been published a few years ago. So I'd say liquid biopsy is better than nothing, at least. I'd say that.
So I know some people send a liquid biopsy on every patient along with next generation sequencing. I know some physicians say, get next generation sequencing and get a liquid biopsy for every metastatic patient. Is that what you do?
That's what I do. I send the tissue and the liquid biopsy at the same time. So I know at least let's say there is not enough tissue in the block, then at least I'll have the liquid biopsy result. And often that's very helpful. And often it is complementary to the tissue NGS.
Interesting. What about the two of you? What do you do?
I would agree. I think if you have metastatic cancer and I'm planning on treating you, get it up front. There's no reason to wait. It's so simple, it's so easy. And really cost has really not been an issue for me. I think that's a big barrier for a lot of people. Out-of-pocket cost usually for patients is very little, and so I think there's really no reason not to. You get the results in probably half the time, and so there's just so many advantages. It's complementary. I don't think it should replace tissue NGS, but I think it should be done in everyone with metastatic disease.
So what do you do at the time of progression then? So some people will rebiopsy at the time of first progression to see if there's any new mutations. Some people wait until second progression. Some people use liquid biopsy. What do you all do when it comes to progression? And when do you decide to do tissue biopsy versus a liquid biopsy versus both versus neither? What's your kind of thinking, thought process, or strategy for that?
I think unlike in some other cancers, that's really not been established in colorectal cancer. But one kind of subset of patients where we definitely do it is patients who have received anti-EGFR therapy previously, and you're thinking about the question of re-challenge. I think in those patients, repeat liquid biopsies are very, very helpful. Now, the other situation where sometimes I've thought about it, getting a tissue biopsy would be HER2/neu amplified. If the patient has progressed, want to make sure the patient is still HER2/neu amplified before, treating them with anti-HER2/neu therapies.
So I have a question specific to HER2 therapies, actually, for any of you. So let's say you have a patient who has HER2, can get Herceptin, can get whatever HER2 therapy, and then they progress on, say, FOLFOX plus Herceptin. Do you continue anti-HER2 therapy when you transition to FOLFIRI? So if you switch to the next line of therapy, do you still continue? Because in some drugs, like Avastin, we've seen that continuing with that therapy actually helps. So what are your thoughts on that for these patients?
No, that's a great question. I think it depends on the pattern of progression of, especially with the anti-HER2/neu therapies. You tend to have like escape lesions, one or two here and there, which you could address with locoregional therapies, and then continue the anti-HER2/neu, the same anti-HER2/neu therapy. But if it's more diffuse progression, we now have the luxury of having a second-line anti-HER2/neu therapy that we could switch to and also maybe look into clinical trials. So that's been my experience. Curious to get your thoughts.
Yeah. So if the driver mechanism is present, so I would continue some form of anti-HER2 therapy. As Arvind said, we need to make sure that the HER2 amplification is still present. As long as it is there, I would continue some form of anti-HER2 therapy. Yep.
And how would you confirm that it was still there? Would you rebiopsy then at that point?
So that depends on patient characteristics. If patient is young and can tolerate the procedure, then yeah, we can do a rebiopsy because that's probably the more traditional approach, although there is no randomized trial between liquid biopsy and tissue biopsy. But we try to get a tissue biopsy, but if I see that patient is older and frail, then I just do a liquid biopsy.
Great.
Yeah, and I think that oligo progressive paradigm you talked about is so critical. I've done SBRT many times to a single, lung lesion that's progressing, single liver lesion, and have been able to continue the same HER2-directed therapy many times. And I think it's a very, very important point.